Hello and good evening to all of you. We are here to discuss this important topic, bridging thromboprophylaxis. And many candidates requested that we should have an online session. Okay, so here it's going to be like a teaching scenario. And yes, I have volunteers, and I can see that you people have joined. And we will try to make it as interactive as possible. Okay, so um, this bridging actually, the medications which were discussed in the exam, one was where there was a scenario patient was on warfarin. There was another scenario where the patient was taking rivaroxaban. And usually the flow charts and tables are given in the exam. The renal creatinine clearance will be given there, GFR, renal function test, patient's body weight will be there, what type of medication she is on, what type of surgery she is going to have. All these informations will be there in the scenario. So your task will be to assess those risk factors and apply them on the flow chart given. Okay, so what we will do, we will be doing this teaching scenario. Of course, we have a volunteer and we will try to interpret and read the charts correctly. I have brought 3 charts today. So we are going to discuss the charts as well. Okay, and there was an important talk article, and I will discuss the tables from those talk articles as well. All right, so hello, Dr. Nagaratna, are you there?
Yes, ma'am.
Very good. Okay. So I will show you the scenario. Take your 2 minutes. Take it easy. Take it easy. It's just like a discussion session. All right. Okay. This is the scenario. Okay. Take your 2 minutes. Okay, you have a flow chart. You can also have a look at that flow chart. You can start. Okay, I'll show you the
Okay.
first slide. Yeah.
No, I want the other slide, ma'am.
Oh, yes. Okay.
Hi, I'm Nagarpana Stephen, and you are?
Yes, I am Dana Green.
Hi, Diana. How are you?
Yeah, I'm good.
Okay. How are you studying?
Yes, everything is going good.
Okay, you find your colleagues supportive and helpful?
Yes.
Good to know that. I understand that you want to learn about bridging thromboprophylaxis and you want to formulate a plan for your patient, right? Am I right?
Yes.
Okay. May I know any specific reason why you want to know about this?
Yes, actually, one thing is that I find this topic very tough. And,
Mm-hmm.
there is a patient, I'm looking after this patient, and we have to follow this patient according to our unit protocol
Yes.
on bridging. So, I find this chart is so colorful and so many things are mentioned. I find it really very difficult to read it.
Yes, everyone feels like that, but it's very easy. Don't worry, I shall explain to you. Once you understand the basics of that, it's just applying this formula for your patient, okay, after identifying the risk. Okay.
Yes.
So I'll be telling you about what is bridging thromboprophylaxis and
Ayun,
why we should do
dali.
that.
Ay, oh, nilay.
Oh, 1 minute.
Dali.
Who is on mute yourselves, please?
Okay.
Your colleague is presenting. Wait. Mhm.
Okay. Diana, bridging thromboprophylaxis is a process where we switch over from long-acting oral anticoagulants to short-acting injectable anticoagulants in the perioperative period in case of elective surgery. Am I clear so far?
Okay, so you mean to say that if a patient is on long-acting oral anticoagulant,
Yes,
like warfarin
yes.
for our patient, we will convert it to the short-acting anticoagulants like
Injectable.
injectables like heparin.
Yes,
Fine, before the
yes,
surgery.
you're right.
Okay.
Yeah. And we should know why are we doing this? Because see, when the patient is on anticoagulant, suddenly if you stop, they are at risk of developing venous thromboembolism, right?
Mm-hmm.
Suppose if you don't stop and if you continue to do the surgery, they are at risk of bleeding during and after surgery. So in order to balance between these two, we are going to do this bridging thromboprophylaxis. Am I clear so far?
Yes, okay.
Okay, okay. So, and why we should before doing this, we should know the category in which the patient falls. For example, low, moderate, high, and very high risk. So, how do we categorize these patients? That is based on the findings like what is the age of the patient, then their weight, then their what type of surgery she is undergoing, major or minor surgery, and what's her renal clearance. So, all these factors will determine in which category she will fall into. Okay.
Okay. Yes.
So once you know the category, then you can use the chart, right? May I have the
Yes.
chart, please?
Okay. Yes.
Yeah, yeah. How do we, before doing this bridging, so we should know information gathering. Information gathering means history, examination, and investigation all together. Why should we know the history? Because we want to know whether she is allergic to some anti-coagulants like heparin, and what is her hemoglobin, whether she is anemic, whether she'll require any blood transfusion, and what is her blood group. All these things we should know in the history, and whether she had any clots or in thromboembolism recently, or whether she had any stroke, and what are the comorbidities. In order to know all these things, we need to take the history. Okay, this is information
Mhm.
gathering. And after knowing all this, we'll categorize her. Okay, so let's see in which category our patient is there. Okay, so
Yes.
what's the age of the patient? She's 53 years, right?
Yes, she's 53 years
Okay,
old.
okay. What's her weight? It's 100, right?
Yes. Yes.
Okay. Now, what type of surgery she's undergoing? Is it major or minor?
It is
She's un
major.
Yeah,
She will be having TAH and BSO for endometrial cancer.
perfect. So she is undergoing major surgery, and we should know her renal clearance. What's her renal clearance in this case?
Yeah,
It's
25.
25.
Yeah.
Yeah. So let's see the chart. Okay.
Mm-hmm.
So in this chart, you have got, see, on the left hand side there is a gray box, the first one. Okay. Here.
Oh,
So
yes.
here we,
Okay.
yeah. Can you see?
Yes, the gray box.
Yeah. Yes, the gray box. So here it's mentioned low risk, intermediate, high, and very high. So our patient is on mechanical heart valve, cardiac valves, right?
Yes,
So
a very high
the
risk
very
mechanical heart
yes,
valves. So first we will
yes. So we'll
categorize the
categorize
patient
them.
in the risk. Very good. Okay.
Yes, correct. So
Yeah.
once you see one factor for very high risk, so definitely she is under high risk.
Mm-hmm.
So now what we should do, see, we'll come to the top. Okay. So very high risk. This we should know from who by whom this is done. It is
Yes.
done by the thrombosis clinic, right? Okay. So that
Yes.
is MDT. So there
Yes.
will be experts. So there we have hematologists and our consultant specialists. They will all formulate this plan. How much of anticoagulation and what anticoagulation to be given for this bridging, and this is done about 1 week before the procedure, right?
Yes.
Okay. And whenever there is very high risk, usually the surgery is deferred or postponed till we optimize the case. Until and unless it is something serious. Like in this case, it's malignancy, so we are worried whether she'll go into
Mhm.
metastasis. So we need to do the surgery, elective surgery now. So we'll be doing bridging. And this is formulated by the thrombosis clinic people. Okay.
Yes.
And now, so there are four charts here, see, green, yellow, orange, and red. So in
Yes.
this red box, can you
Yes.
see on the right hand side? Yeah. So
Yeah.
that is very high risk.
Mm-hmm.
So they will give you what you should do, what is the anticoagulant, and usually
Mm-hmm.
depending on the anticoagulant she's taking preoperatively. In this case, she's taking warfarin, right? So there will be a different protocol, formulated one, ready one in the unit. We have to follow always unit protocol. In this particular hospital, they are following this for this anticoagulant. So this chart is for warfarin. Okay. Similarly, there will be different charts like for rivaroxaban or dabigatran. There will be different chart. So
Yes.
this is applicable to warfarin in this unit. Okay. So we have chosen. Now come to the lower half of the chart. See,
Mm-hmm.
can you see here this box F and G? Can you see? There
F
is weight of
and
the patient here.
G. Yes.
F is
Yes.
here.
F and
F,
G. Yeah.
F and G. See, now we
Mm-hmm.
should know whether she's taking prophylactic anticoagulant or therapeutic. She is on the therapeutic dose, right? Because she is having mechanical heart valve, right?
Yes. Yes.
So come down in this F, the G. Okay, here
Yes.
her weight is 100 kg. Come down.
Yes. Yes.
See here. So
Okay.
correspondingly, in this blue purple thing is given. Creatinine clearance is there.
Yes. It is less than
Okay.
30. So our
Yeah.
patient is having 25.
Yes. Yes.
So we will
So
follow this
she
chart
will be.
and
Yeah, we are following. She will be requiring 12,500 units.
right. Okay. Because the weight
Am
is
I clear?
100 kilograms. Yes.
It's above 85.
85. Okay.
And the renal clearance is less than 30. So it's
Mhm.
fall into this category. Am I clear so far?
Yes. Yes. Very clear.
Okay. So we have chosen the anticoagulant and then the dose, and also see this factor 10A levels we should measure whenever there is extremes of weight, that is less than 50 or more than 90. Okay. So
Yeah.
this we'll have to do, right?
Yes.
So we will be giving this and adultipanic, and you should know when to stop the anticoagulant, oral anticoagulant before
Okay.
surgery.
Mm-hmm.
Okay, so usually it's in this particular unit, they stop it on the 36 hours before. Okay, so usually in the
Yes.
graph, in the chart, it will be depicted -3, -2, -1 like that.
Yes.
Minus means before surgery.
Yes.
If it's written as -3, you should stop that drug 3 days before. If it is -2, stop it before 2 days, right?
Yes. So here, according to my protocol, we will stop
Yeah.
warfarin 4 days before the procedure, day -4. Right?
Your
And
protocol meaning in
yes.
this chart,
Yes.
yes.
We will follow
Yeah.
this flow chart.
Yes, you have to follow
Yes.
this. So you
Yeah.
have stopped that, and then we'll start her on unfractionated heparin. Okay.
Yes. We will start IV
Yeah.
fractionated heparin.
IV
Okay.
unfractionated heparin after ruling out allergy. This is very important, right?
Yes. Yes.
And then she will undergo surgery. Then once the surgery is done, after the surgery, we should know when to restart. Usually, once the epidural cannula catheter is removed, and if there is no risk of any bleeding, then we'll start the oral anticoagulant again. And
Yes.
see, we should know what is the dosage of warfarin required in the post-operative period, again for restarting. How do we calculate that? We'll do INR,
Yes.
and then if the INR is less than 1.5 range, then we'll give 1.5 times the original dose. For example, she was taking 5 milligrams preoperatively, so 1.5 times is 7.5 milligrams.
Mm-hmm.
Okay,
Yes.
5 plus 2.5, 7.5 milligrams you'll give for 3 days only. This
Right.
again you'll
Okay.
go back to her original dosage.
Yes.
Okay, am I
Mm-hmm.
clear so far?
Yes, very clear.
Okay.
Okay.
So this is the bridging thromboprophylaxis. Okay.
Right. Okay.
Anything else you want to know?
No, thank you. Okay, your time is
Okay.
up. Okay.
Okay. Thank you. Thank you.
Thank you. Thank you, Dr. Nagaratna. Thanks for coming up and explaining the chart beautifully. All right. So when we see this type of chart in the exam, and suppose we don't have any idea how to read the chart, of course, we will be very stressed out in the exam. So the scenario here, is like, since we are discussing the teaching station, so some thoughts should come in our mind, like communication with colleague. Yes, your explanation was absolutely fine. I was feeling comfortable with you. And since we are talking about the bridging, and this lady is having endometrial cancer, also a mechanical heart valve, creatinine clearance is less, so we can involve our other colleagues, consultant, like your nephrologist, cardiologist if needed, the surgeon who will be operating. If oncosurgeon is there, yes, we will involve him, and the specialist nurse, the pharmacist in the bridging clinic is very, very important. All right. Information gathering will be like what information we will be extracting about this lady is important. The risk factors is very important, so that we are able to categorize our patient in low risk, intermediate risk, high risk, and very high risk. Patient safety, applied clinical knowledge, all nearly they go hand in hand. So yes, the patient safety points which you said, ruling out any allergy, taking history of antiphospholipid syndrome, thrombosis. So these are important points. Applied clinical knowledge, how we are doing the bridging, and when we are stopping the warfarin. Then for the bridging, what will be the dose of the heparin? And again, when we are going to restart oral anticoagulant, if there's still risk of bleeding, then yes, we will be patient will be having the thromboprophylactic dose of heparin. We can give that. INR is very, very important. All right, so since it's a teaching station, so yes, your introduction and communication is absolutely fine. You have your colleagues, so rapport building was absolutely fine. That, hello, I'm Nagaratna, and you are, okay, hi, Diana, I understand you. Hi, Diana, how are you doing? And how's everything in the department? Do you feel very well supported here? I understand you want to know about the bridging thromboprophylaxis. Am I right? May I know why do you want to know about it? Do you have any idea about it? Have you read about it? Okay, she said she find it very difficult. Okay, no worries. So what we will do that we will be reading this chart together, and I will also discuss with you that what is bridging thromboprophylaxis, how do we do it, and we will go through this flow chart together, and we will discuss how to do bridging for your patient. Is there anything in particular you want to know? Any other concern and expectations from today's meeting? All right. So, okay. So, Diana, I will also be giving you the important articles and links and talk article regarding the bridging thromboprophylaxis. Okay. So, it is important to ask your colleague whether she wants to know anything in particular, because you have your task given, but maybe she wants to know something extra. So then when you will talk about that extra thing, then you're going to get marks, because maybe she will be having some other expectations from you regarding this particular topic. Now, you will be explaining to her what is bridging thromboprophylaxis. So you very well explained. It means replacing the long-acting oral anticoagulant to short-acting injectable anticoagulants like heparin in patients going for elective surgery. And why we do it? This is done until a patient can safely restart the oral anticoagulant, and this helps to reduce the risk of major intraoperative and postoperative bleeding. Then you can just ask, what is bridging thromboprophylaxis? Can you repeat? Yes, excellent. This is what we do in the teaching scenarios. So why do we do this? There has to be a balance between the bleeding risk and the thrombosis risk. Because if we stop oral anticoagulants simply, this will increase the risk of clots. And if we continue the oral anticoagulants, this will increase the risk of bleeding. So the concept is we have to give alternative anticoagulant like injectables, for example, heparin, with shorter half-life and which are short-acting because their side effects can be more readily reversed and managed. And we should avoid any cancellation or delay in treatment or surgery. So this is the advantage also, that if we are doing the bridging carefully, this will avoid any cancellation or delay in treatment by surgery. Okay. Then comes your information gathering part. It is very important because we should know the risk factors for thrombosis in our patient. This will help us to classify our patient as low risk, intermediate risk, high, or very high risk. So how do we do this? By history taking, examination findings, and by the investigation results. Then you will ask that, okay, so let's see the risk factors in our patient. Age is 53, weight 100 kilograms. What about the medical conditions? Yes, she's having endometrial carcinoma, and also she's having mechanical heart valve, any liver or kidney condition, and she's on the medication warfarin. And we can ask since when she's taking it, what's the dose. And also we have to rule out any allergy, particularly allergy to heparin or like any previous history of heparin-induced thrombocytopenia, or whether she has ever used heparin before. Surgical history, any previous surgeries, smoking history, how about the support, and confirm the blood group, and also if she has any reservations for blood transfusion because there is risk of bleeding and she might need blood transfusion. So examination, we will be assessing her general condition like her pulse, blood pressure, pulse, temperature. Usually these observation findings are given in the exam. You will be having a chart. Usually it is like that. What investigations are important? So renal function test was done and the creatinine clearance is 25. So it is less. Other investigations are important. We should know about a full blood count, hemoglobin, platelet count, coagulation profile, and LFT. And when we are going to do the bridging, then INR is important. So now we will classify the patient because we have to calculate the dose of heparin. Either it is therapeutic or prophylactic dose. This will be according to the chart. And this patient is a high-risk one, so she will be having the therapeutic dose of heparin. So then you will discuss that how are we going to manage further this patient. MDT involvement is very, very important. So who will be in the team? Consultant, operating surgeon, hematologist, pharmacist in the anticoagulation clinic, oncosurgeon, anesthetist, cardiologist, nephrologist, specialist nurse, and also we will consider the wishes of the woman. So we always have to keep the patient in consideration. All right. So MDT is also a very, very important part. Like MDT is not only communication with colleague, it is patient safety as well. Then you are going to explain the flow chart. So what is happening here, that now we know that after our patient is a very high risk, so you will see where is our patient, low risk. So patient is having mechanical heart valve. Okay, so mechanical heart valve is mentioned here. So our patient will be in the very high risk. Okay, so we are going to exclude low risk, intermediate, high risk. No, she is in the very high risk group. Now for the very high risk group, how we will manage, we will see the flow chart here, that how, what is the dose of heparin to be given to the patient. So low risk, intermediate, high risk, very high risk. So we are going to follow this box. Before that, there are some other important points which we are going to talk about. When are we going to stop the warfarin? So we are going to follow this flow chart. It is stopped 4 days before the surgery, so it is day -4. Important points in the history, we should know whether the patient is having antithrombin deficiency or antiphospholipid antibodies, whether she has any allergy to heparin or any history of heparin-induced thrombocytopenia. Everything is right in front of you. It will be in the exam. So just try to read and explain it to your junior. Now, if patient is having these risk factors like antithrombin deficiency, antiphospholipid syndrome, heparin allergy, history of heparin-induced thrombocytopenia, yes, then what are we going to do? We have to contact the bridging clinic or thrombosis specialist registrar. All right. Now, patient is not having these histories. Then we are going to follow this box. She's a very high risk case. We will come to the box D. Now, preoperatively, when are we going to admit the patient? On day -3. And we are going to start the IV unfractionated heparin infusion when INR is less than 2. So the drug of choice given here for the very high risk patient is the unfractionated heparin. And INR is a very important investigation. And when are we going to stop unfractionated heparin? Just see the chart, 4 hours before the surgery. So usually we stop it 4 to 6 hours before surgery. Very clear. Okay. Now, if they have also mentioned about the low molecular weight heparin, because we know it is easy to use, isn't it? It doesn't need so much of monitoring like your unfractionated heparin. So here they have mentioned that we can consider giving the treatment dose of low molecular weight heparin. But we should keep in mind that it is an unlicensed option. So we have to obtain the patient consent. Okay. So if patient wants to have low molecular weight heparin, then how are we going to give it? What is going to be the dose? So they have mentioned, you will see the box E. All right, now you will search where is the box E. Okay, this is the box E. So they have mentioned about the bridging therapy in the renal failure. So either they have mentioned about table F and table G. So table F is for the prophylactic dose and table G is for the treatment dose. That is the therapeutic dose. So for our patient, it's going to be the treatment dose because she's a high risk case. So we will see the weight of the patient. It was 100 kilograms. So she falls here more than 83 kilograms. See the creatinine clearance more than 30. No, it's not suitable. Less than 30. Yes. Creatinine clearance is 25 in our patients. So we are going to follow this box. So the dose is going to be 12,500 units. Suppose there was an indication where we can give the prophylactic dose. So how are you read this box? See the weight of the patient. Where is the weight? 100 kilograms. So this is the 100 kilogram. And creatinine clearance is less than 30. So follow this one. It's going to be 105,000 units, isn't it? Then now we know we have done the pre-op management. Now comes to the post-op management. When are we going to restart the heparin? So we will restart IV and fractionated heparin infusion immediately post-op as soon as the bleeding has stopped. But here we have to take care of the epidural insertion. So if like epidural insertion was done smoothly, there was no trauma to the patient, we can start it 2 hours later. But if there was any traumatic epidural insertion, then we are going to start IV and fractionated heparin 24 hours later. And we have to keep checking the INR until target INR on 2 occasions is reached. Right. Then we have to see where, okay, one important point also is here about the anti-10A level testing, okay, in the renal failure. So yes, we do anti-10A testing in patients with renal failure and also in extremes of body weight where the weight is less than 50 kg or more than 100 kilograms. Then comes when do we restart the oral anticoagulate. So again, we have to see that the bleeding has reduced. So if still there is excessive bleeding, then ideally we will start oral anticoagulant on the evening of the surgery. And again, we will be involving the surgical consultant or the specialist registrar. Or we will start once oral intake is established, of course, when the bleeding risk is less and oral patient is taking orally. Now, what will be the dose? So for the dose, usually these patients are on 5 milligram of warfarin. So it will be 5 milligram multiplied by 1.5. So it's going to be 7.5 milligram, okay, in the first 3 days. And After that, it will be the usual dose of 5 milligram. So everything is mentioned in the box. You don't have to memorize so many things. Usually the box is given there to make your life easy. The only thing is that you should know how to read the box. Then something is mentioned here about the follow, which is very, very small. So I have mentioned it later on. So one moment. Okay. So regarding the follow, what is said that like the patient should be having the follow-up in the local anticoagulation clinic, and within 3 days if there is only 1 INR in range, within 5 days if 2 INRs are in the range. All this is given in the box. Anti-10A level monitoring we have discussed, okay, in renal failure cases and extremes of body weight. So suppose, now I have one question. So again, someone of you can answer. If the colleague asked that how are we going to reduce the risk of bleeding in this patient? What should we do preoperatively, intraoperatively, and postoperatively? How to reduce the risk of bleeding and thrombosis, both? Who will answer this?
Right?
Ma'am, we can
Yes.
uh, uh, preoperatively we can optimize the hemoglobin level of patient, and also we can just plan the thromboprophylaxis, and during intra-op we can follow the meticulous surgical technique in order to reduce the risk of bleeding. We can always ask the consultant for consultant help for surgery, and all the measures like for proper hemostasis, that all we can do to in order to reduce the risk of bleeding during the surgery.
Yes.
And also like and postoperatively what we can follow, like proper monitoring in news chart, and then early mobilization, proper hydration, and of course later on uh, during and then we can temporarily bridge it with IV unfractionated heparin, and then only later on we will start the oral anticoagulants.
Right. So this is
And the usage of
Khushbu
antidote if
speaking.
at all still bleeding is there.
Yeah, this is Dr. Khushbu, right?
Yes, ma'am.
Yes, very good. So principles of enhanced recovery program should come in our mind, but yes, we have to apply it according to the scenario. So yes, preoperatively, what you said, we will be checking the patient's hemoglobin, treat any anemia, optimize the hemoglobin because there is increased risk of bleeding, and discuss about the blood transfusion if needed, and intraoperative cell salvage. And it is very important to document the bridging plan, right? Intraoperatively, yes, we will involve the consultant and the seniors in the surgery, use meticulous surgical technique, minimally invasive surgeries if it can be done, secure the proper hemostasis and use hemostatic agents. We can also use intraoperative cell salvage, drains can be used. And postoperatively, we will follow the bridging thromboprophylaxis. Patient may need admission in high dependency unit. She will be kept under close observation. Observation will be maintained on the news chart, and offer elastic compression stockings, encourage early mobilization, and maintain the adequate hydration. Fine, and we are always going to start heparin once the bleeding stops. Okay, now let's talk about the antidote. Antidote for heparin and warfarin.
For warfarin, it's vitamin K, and for heparin, it's protamine sulfate.
Right, okay. So for heparin, protamine sulfate, and if it is not so effective, we can use the fresh frozen plasma. For warfarin, it is vitamin K. All right, so these are also the patient safety points in this scenario. We will be telling the junior about this antidote as well. And if this, like women, is at very high risk of thrombosis, then surgery can be deferred until the risk of thrombosis is low. And assessment for the thrombosis, the risk assessment of thrombosis is usually done 7 days before the surgery. And the documentation is very, very important. And this will help us to give effective perioperative anticoagulation, and we can plan the anticoagulation therapy effectively. Then in the end, yes, you will be closing the station, ask for the feedback. So how was the session? How did it go? And if you have any query, please feel free to ask me, and I will be giving the important articles on bridging. All right. Now we have two more charts. So who wanted to read this one? I think Khushbu and Dr. Musarrat. So
Yes, ma'am.
yeah, okay. Try to read this one. It is a bit
Ma'am,
hazy.
basically,
Yeah. Yes. This
yes.
is
Ma'am,
about the NOAC.
basically, it's the,
Yeah. Okay.
yes, ma'am.
Mhm.
So these chart are like unit protocols, what generally in exam they give us in order to ensure that we read the chart and we follow this chart, whether we are reading it and follow it accordingly. So first of all, like looking at the first row, we have to know that when was the last VTE episode occurred.
Yes.
And then we generally determine about the type of procedures what we are doing, whether it's a minor surgery or it's a major surgery.
Yes.
And then we next column we follow the creatinine clearance. So generally more than 80 is good, 50 to 80, and then 30 to 50. So they have categorized it accordingly, and according to the level of creatinine clearance, they
Mhm.
have made a protocol that uh, when we have to start or restart the oral anticoagulants like dabigatran or rivaroxaban.
Yes.
Uh,
This
and the
is the
next column is
last dose. Yes.
Mhm. and next column is like depending upon the creatinine clearance.
Hmm.
So last oral anticoagulant prior to surgery, when we have to stop, I mean for at least 48 hours prior to the surgery we have to start. So that is also based on the creatinine clearance. If it is more than 80, then dabigatran should be stopped 48 hours prior, rivaroxaban 48 hours.
Yes.
So this column is for those surgeries.
Mhm.
And then uh, next column next column is basically as per the body weight and the amount of and the dosage is given, how much
Yeah.
dose we 32
Yes. This is the
mm, mm,
post-op care. If the patient
mm,
is still having ongoing bleeding, then we will be
mm,
doing the bridging with prophylactic dalteparin. So this will be according
mm,
to the weight
mm,
and with the creatinine clearance. Right.
mm,
So if we apply, like our patient's weight is 100 kilogram, isn't it? So we
mm,
will
mm.
follow this one, isn't it? I know it's a bit
Yes,
hazy.
ma'am. Mm.
And
So
creatinine
here,
clearance is
yeah,
less than 30. So we will follow this
mm,
blue one, isn't
blue.
it? Yeah.
Mm.
So
So
it
it
will
will
be
come around 5,000 OD,
5,000 units.
5,000 once a day,
Yes,
5,000 unit once a day.
once a
It will
day. We
come.
will follow the flow chart.
Mm.
Exactly. Right.
Uh, then the
Yes. Okay.
I
So
cannot.
let me,
Yes.
okay. So
Mm, mm,
one by one. After that, we have one
mm,
more chart. Okay. So like you said,
mm,
suppose we have rivaroxaban in the exam. We know it is a direct or
mm,
new oral anticoagulant.
mm,
So we have to see when the VTE occurred. More than 6 weeks, or if in last 6 weeks, then of course we will be discussing this with the thrombosis team. It's a very, very
mm,
high risk case, right?
mm,
Then we will see whether it's a minor surgery or a major surgery. So in our patient, it's going to be the major surgery because she's having
mm,
abdominal surgery, TH and BSO, right?
mm,
And in the exam, it was rivaroxaban. So now we will see rivaroxaban and the creatinine clearance. So creatinine clearance was actually less than, it was less than 25. That box is not given here, but 30 to 50 is given. So like if we can follow this one, if it was given less than 30, that would have been more appropriate. And uh, so we are only going to stop the rivaroxaban 48 hours before. This is the timing of last NOAC dose pre-procedure. Okay. You don't have to mug up everything. I will show the flow chart given in the talk as well. Okay. So the idea here is that preoperatively, no bridging is done, isn't it? They have not mentioned anything about the heparin. They have just said we are going to stop rivaroxaban. But post-operatively, now the flow chart has mentioned that we have to assess the bleeding risk of the patient and the risk of VT. So if there is no bleeding, hemostasis is achieved and there is no risk of bleeding, no further surgery planned, then we can restart the pre-admission dose 6 to 8 hours after the wound closure. That is, they are talking about the rivaroxaban. Now, if there is ongoing bleeding, so what we have to do, we will be doing the bridging with prophylactic dalteparin. Okay, so here we are going to give the first dose 6 to 12 hours post wound closure if hemostasis is achieved. So, and if traumatic epidural catheter was there, then we are again going to wait for 24 hours after insertion before starting dalteparin. Then we will see the dose of dalteparin according to the weight of the patient and according to the creatinine clearance. So here it was 100 kilogram, like you said, and creatinine clearance is less than 30. So the dose is going to be 5,000 units. This is OD dose. All right. And if prophylactic dose here actually it is more than 30, so we are not going to follow this one. For our patient, it's going to be less than 30. And we have to seek the hematology advice. Very, very important. Okay, so this is how you will be reading the flowcharts. Keep in mind the weight of the patient and the creatinine clearance. All right, thank you. Now, who is going to read this one? This is also for the direct oral anticoagulants. Dr. Musarat, have you joined today? Okay, if she's not there, anyone will try?
Me?
Whose voice? Khushbu. Yes,
Khushbu, ma'am.
please. Of course.
Hmm.
Yes.
So this chart is for dabigatran, which is a direct 10A inhibitor. So we determine whether the risk of bleeding is high or low. So our surgery, abdominal surgery, so the risk is high. So we will see the the column of high. Then they are telling that when we have to omit it, so 2 days prior to surgery, we will omit it, this yellow.
Okay.
And prior to this, we will continue the oral anticoagulant. 2 days
Yes.
before surgery, we will omit it. On
Yes.
the day of surgery, we will do, on the day of procedure, we will not administer any direct anticoagulants. That's what the red has mentioned, red line.
Yes. Yes. Mm-hmm.
Then after 1 day of the surgery, it will be still omitted only.
Yes.
And on post-operative day 2, we will restart it
Yes.
because they have shown green. So we will resume on either day 2 or day 3 of the surgery. This second column, resume day 2, day 3. And day
Yes.
4, it will be still continue as usual.
Yes. Okay.
And the next column also, but here our creatinine clearance was less, so we will follow the
Less than
next one,
50. Yes.
less than 50. So we will
Less than
follow this
50.
one.
Then we will
Uh,
follow this one for
yeah,
the dabigatran. Yes.
dabigatran less than 50. Surgery is high risk, so we will follow the higher column. And here we will stop it 4 days prior to surgery. We will omit
Yes.
pre-operatively. We
Yes.
will omit on 4 days prior to surgery. We will continue. We will just omit, and on the
Mhm.
day of surgery, we will do not. We don't administer any anticoagulant,
Yes.
and then it will be omitted on the day 1 also post-operative.
Mm-hmm.
It will be restarted on post-operative day 2 or either day 3. We will
Yes.
restart it.
Exactly. So this is how you will explain to your colleague in the exam. You don't have to mug up everything. Everything will be right in front of you. So
But I think,
these
ma'am, what I realize, it will take consume so much of our time, like by telling all these things.
uh, means when you will
Like,
get
I
the
mean, in
chart, it will
real
move.
exam, in 10 minutes, it will consume time.
They will give one flow chart. They're not going to give warfarin and direct oral anticoagulant both. So yes, here, because you have to explain the chart. So yes, you will see direct oral anticoagulant and the creatinine clearance. So they have mentioned direct 10A inhibitors, means these are rivaroxaban, apixaban, all of them, and dabigatran. So we know dabigatran is slightly different from other direct oral anticoagulants. So in the exam, it was rivaroxaban. Okay, but don't stick to that. They can even give dabigatran, right? The idea is that we should know how to read the chart. So, like you said, our patient is like high risk. But so if rivaroxaban is given, forget about dabigatran. You have mentioned dabigatran nicely. If rivaroxaban is given and our patient is like the category is going to be the high risk, then when are we going to stop it? Day -2, at least 48 hours before the surgery, isn't it? Again, so day -2 we have stopped, and on the day of surgery we are not going to give any oral anticoagulant. Even after the surgery, it will be omitted, and it is started on day +2 or +3. Any questions, anyone so far? I hope you people are able to read this box. Omit here. So suppose the patient, okay, we will come to this one. If the patient is having a low risk of bleeding, then when are we going to stop the medication? On day -1, on the day 0, that is day of surgery, nothing is given, but we can restart it on day +1. That is soon after the surgery. Okay. So now the thing is that if there is emergency surgery, that was all about the elective surgery. Then if patient is on antiplatelet and she is having monotherapy, aspirin, then what should we do? Should we stop it or can the patient continue it?
You can continue.
Patient will continue.
Continue.
Very good. If patient is having dual therapy, aspirin and clopidogrel, there is low risk. Low risk, then what we will do? Low risk during the surgery?
You can continue, or clopidogrel only will be stopped before 7 days.
Okay, yes, see. She is having dual therapy, both aspirin and clopidogrel. So if delay is possible, surgery can be postponed for 6 months. If delay is not possible, we will consult hematologist. If low bleeding risk, both can be continued, aspirin and clopidogrel both. But if it is high bleeding risk, then as you said, only aspirin is continued, and we will stop clopidogrel. And usually, yes, clopidogrel is stopped 7 days before the surgery or 7 days before the regional anesthesia. All right. Now, what about the warfarin? What we should do? If possible, we can delay the surgery for 6 to 8 hours and give the antidote, vitamin K. If we are not able to delay the surgery, then what is given to reverse the effect of warfarin? That is
Factor
yes,
concentrate.
yes, 4-factor prothrombin complex. Yes, it contains 2, 7, 9, 10. Yes,
9, 10.
Exactly. Now, if we have direct oral anticoagulants, if we can delay the surgery, okay, fine. But if we are not able to delay the surgery, then what we should give to the patient?
Tranexamic acid.
Yes. And we will avoid non-steroidals. So we will give tranexamic acid and we will avoid non-steroidals. For dabigatran, yes, there is a medication, idarucizumab, that is given in the talk, right? Now we have clopidogrel. So we know there is no specific reversal agents, but like you people said, we should discontinue it 7 days before the surgery or before regional anesthesia. And if there is high risk of bleeding, we are going to give tranexamic acid. After giving tranexamic, still there is bleeding, then we will give 2 pool of donor platelets. Now, I'm not going to read each and everything. This is from the talk. So we will see where in which category is our patient, what were the complications she was having, right? So patients with high thrombotic risk who should be considered for bridging with treatment dose heparin when they stop warfarin. All right, so patient was having the mechanical heart valve, so she will need treatment dose of heparin after stopping warfarin. Now, which medical procedures are associated and their associated bleeding risk? So there is no bleeding risk in these procedures, minor bleeding risk, major bleeding risk, all day case and inpatient surgery. And of course, abdominal surgery like in our patient. Now, here, as per this talk, regarding the warfarin, what they have mentioned, their half-life is very long, isn't it? Approximately 36 hours. Okay, so when are we going to stop it before the surgery? For both low bleeding risk and high bleeding risk, should be stopped 5 days before the elective surgery. And we have to check the INR. If INR is more than 1.5, we are going to give vitamin K. So we have to check INR ideally the day before the surgery and also on the day of surgery. This is both for low and high bleeding risk. Now, in the high bleeding risk, what it is mentioned that we have to do the bridging with treatment dose of low molecular weight heparin. Okay, it should be considered in those with high VTE risk. Then, when are we going to restart warfarin? So, if low bleeding risk, we can start the warfarin when adequate hemostasis is achieved. The bleeding risk is less, approximately 12 to 24 hours after the surgery. Low molecular weight heparin can be restarted 24 hours after surgery until INR is in the therapeutic range. But for the high bleeding risk, what they have mentioned, for the low molecular weight heparin, we will wait till at least 48 hours after the surgery. And for warfarin, they have mentioned restart when the bleeding risk is minimized. And at all times, we have to check the INR. And for high bleeding risk, we also have to talk about the mechanical thromboprophylaxis. Now, coming to direct oral anticoagulants, apixaban, rivaroxaban, edoxaban. They are all factor 10A inhibitors. They all have same mechanism of action. So here we have to see whether surgery is of low bleeding risk and what is the creatinine clearance. Creatinine clearance is normal, 30 ml or more. Then we will be stopping these medications 24 hours prior to the surgery. This is about our direct oral anticoagulants. If the creatinine clearance is less than 30, it has to be stopped 48 hours prior to the surgery. And when are we going to recommence them? After the surgery, at least 6 to 12 hours after the procedure. Okay, so again, here they have not mentioned anything about the bridging in the low-risk patients with the direct oral anticoagulants. If there is a high bleeding risk, again, we are going to check the creatinine clearance. So if the creatinine clearance is normal, 30 ml or more, we will stop these medications 48 hours before the surgery. But if creatinine clearance is less than 30, we will stop 72 hours prior to the surgery. When we will stop? Now, there is a high bleeding risk, so we have to wait at least for 48 hours before starting these medications at full dose. Now, if still there is bleeding risk, right? And also there is risk of thrombosis. So we will consider the prophylactic dose of anticoagulation. So heparin can be given, but only the prophylactic dose before restarting the therapeutic dose. Fine? Okay. Now, regarding the dabigatran, here it's going to be different. See, it's very difficult to memorize everything. You're definitely going to get a chart in the exam. This is mainly for the part 2 people. For the part 3, it's not easy because we are OB-GYNs. We are not hematologists, right? So such type of station is there, then you will be involving your MDT. And now here if we talk about dabigatran, then if the low bleeding risk, again, you have to check the creatinine clearance. Too many things to remember. If creatinine clearance is 80 ml or more, then it stops 24 hours prior. More than 50 to less than 80, stop 48 hours before. And 30 or more to less than 50, stop 72 hours before. Very difficult to memorize. Okay. And then when we are going to start, so this is same. We will be starting at 6 to 12 hours after the procedure. In high bleeding risk, then we will be stopping. See, you can see this is all 24, 48, 72 hours and 96 hours here. So 80 or more, we will be stopping at 48 hours prior to procedure, 50 or more to less than 80, 72 hours before. Then again, 30 or more or less than 50, stop 96 hours before the procedure. So in the exam, you will see the creatinine clearance, what is given, what is the clearance, whether it is 80 ml or more, whether it is 30 ml or more, whether it is less than 30 ml, what is the bleeding risk, low bleeding risk, high bleeding risk, and what are the risk factors in the patient, the weight of the patient, what type of surgery she is going to have. Okay, so if high bleeding risk, then when are we going to start? Again, we have to wait for 48 hours. And if high bleeding risk, then we can give the prophylactic dose of anticoagulation. Okay, I hope this is clear. Any questions so far? That was all for this one. And coming to the antiplatelets, so we have just discussed, if patient is having monotherapy aspirin, we will not stop monotherapy. We will continue, isn't it? Because the half-life is also very less, and like it will not increase the risk in the patient. But if patient is having dual therapy, aspirin and clopidogrel, then we will see whether it's a low bleeding risk, she can take both the medications. If it is a high bleeding risk, then we will see whether we can postpone the surgery. If we can't postpone the surgery, then we are going to stop clopidogrel just 7 days before the surgery, and aspirin is continued with liaison with the hematologist. So at all time, we have to involve our MDT. Okay. Any questions? Anyone has any confusion in reading the charts? I hope it is clear. I hope so. I think that's all for today's session. Because I just wanted to keep it to the point and very crisp, and just wanted everyone to participate to make it little interactive. All right, so thank you
Ma'am,
so much. Yes?
ma'am, if the patient is on mechanical heart valve, so do we still continue oral anticoagulant in those patients in heart valve and high risk of, and if we are doing hysterectomy and all, but or even in those patients we
Usually it will be stopped. The oral anticoagulants should be stopped. Because see, rivaroxaban and all, as you will see the flow chart, they have to be stopped. And it all depends upon the creatinine clearance. So it is not just about patient having mechanical heart valve and direct oral anticoagulants. So we have to see the renal function test of the patient as well. And accordingly, we have to stop it. But if there is low bleeding risk, usually pre-op bridging thromboprophylaxis is not given. But if there is a high bleeding risk, then if we stop it, suppose 72 hours before the surgery, then of course we have to liaise with hematologist and we have to see whether any bridging thromboprophylaxis should be given or not. So the idea is, as you're going for the exam, so you have to involve the MDT as well. But yes, these medications needs to be stopped. And usually patients with mechanical heart valve, still warfarin is considered to be superior than rivaroxaban. Okay.
Yes.
Right. Any more questions, anyone? just go through this talk. You know, if you people have read the talk and you have come to attend the session, that's absolutely fine. But now, since we had this discussion, so if you will go through that talk, it will be very easy to understand. Okay, I have one question. So regarding the oral contraceptive pills, when it should be stopped before the surgery and when should it be restarted?
4 weeks before it should be
4
stopped.
weeks
Yes,
prior to surgery, we stop.
yes, 4 weeks prior to surgery stopped. And when should it be restarted?
6 weeks after the procedure.
It is given 2 weeks after the procedure, provided that the patient is mobile and she's well hydrated. Okay, actually, there is a talk on another thromboprophylaxis and the risk factors. I think that was an old talk, so they have mentioned that one. Regarding the HRT, they have mentioned that no need to stop it, but we will consider HRT as a risk factor to calculate the risk for development of thrombosis. But COCP has to be stopped. It's mandatory to stop it. And if you will not stop it, then you will have to write an incident report, because you can get scenarios like that also, isn't it? That patient was still having COCP and she developed thrombosis. I mean, she had undergone surgery and then she developed thrombosis. Okay, my dears, I hope this was helpful
Thank
for
you,
all
ma'am.
of you. Okay,
Thank you.
Yes, ma'am.
thank you.
Thank you.
Thank you.
Thank
Thank
you,
you.
ma'am. Thank you.
All right, my dears. Okay, thank you so much.